his left third toe. Left third toe. During the past 36 hours, he has not slept because of the pain. He has coronary artery disease, hypertension, hyperlipidemia. 6 years ago, he had MI. Never undergone an operation. Medications are um, lisinopril, ramipril, labetalol, aspirin, acetaminophen, ibuprofen have provided no relief. He smoked a pack of cigarettes 40 years, quit 6 years ago. He appears uncomfortable, pulse is fine, BP super high, 4 centimeter pulsatile non-tender mass is palpated in the left inguinal region. The left toe is necrotic and exquisitely tender to palpation. There is no redness or drainage. Vital pulses are fine on the left. Reminder of the exam is fine. A CT scan of the abdomen and pelvis is shown. In addition to IV analgesics therapy, which of the following is the most appropriate next step?
Okay. Okay, surgical arterial repair. Femoral artery aneurysm. Femoral artery aneurysm often involve femoral artery and are frequently associated with peripheral arterial disease. Risk factors include male sex, older age, male sex, older age, tobacco use, hypertension, hyperlipidemia, and coronary artery disease. Hypertension, hyperlipidemia, coronary artery disease, all of which are seen, all of which are seen in this patient. Symptoms can vary, with some patients being asymptomatic when present. However, symptoms include a pulsatile groin mass and vascular claudication. Femoral artery aneurysm can be complicated by acute limb ischemia, rupture, and distal embolism. Diagnosis often includes ultrasonography of the groin and CT angiography. Symptomatic patients are those with large than more than 3 centimeter aneurysm should undergo surgical arterial repair. These patients with numerous cardiovascular risk factor presence with third toe ischemia most likely caused by thromboembolism in the setting of pulsatile groin mass felt on physical examination. This pulsatile mass can be more clearly seen and this pulsatile mass can more clearly seen as an enlarged femoral artery with intraluminal thrombus on CT scan. Thus, the most appropriate next step in the management of this patient is surgical arterial repair. Okay,
Can you read number, sorry, B, C, D?
yes. Okay. Patients' placement of Anna boot is often used in the treatment of venous stasis ulcer. Venous stasis ulcer. It is a compressive dressing that contains. It is a compressive dressing that contains zinc oxide, which expedites healing. This would be inappropriate for this patient as it would not treat the underlying cause of his necrotic toe. Placement of a vena cable filter is used to prevent the embolization of the deep vein thrombosis to the pulmonary vasculature in patients who have contraindication to anticoagulation. This patient has no evidence of deep vein thrombosis. This patient has no evidence of deep vein thrombosis on physical examination. R- Rather, he has toe ischemia. Rather, he has toe ischemia caused by embolism. And rivaroxaban therapy is an anticoagulant used in the treatment of deep vein thrombosis, pulmonary embolism, and atrial fibrillation. While anticoagulation may be warranted in this patient, initiation should be delayed until surgical arterial repair as it can increase surgical bleeding.
What
Okay,
is the what is the aneurysm on the CT scan? Is it this?
I don't get it. I
Oh,
don't know.
okay. I'm like, okay. Okay. Next. 37 woman comes to physician requesting assistance in applying for disability income. She fell at home 12 months ago and had left her job at the daycare center because of subsequent low back pain. She received a diagnosis of MBD 8 months ago. Her sleep appetite and mood have improved with SSRI. Her only other medication is ibuprofen. She asked the physician to document a permanent and total disability on an application form. For disability, consults that she will have financial resources to start college education on a full-time basis. She explained that she will become depressed again if she resumes her stressful job in the daycare. She does not appear to be in distress. BMI is fine, temperature fine, pulse fine. BP a bit low, exam of the back shows no tenderness, range of motion of the lumbar spine is fine, neurologic exam is fine. The physician will not fill out the form. In addition to performing, in addition to informing the patient, which of the following is the most appropriate next step in management?
Okay. So, lying is viewed negatively in most philosophical systems because it exerts a morally negative effect on the person telling the lie, violates the autonomy of the person who lied, who is lied, and undermines trust in the society. It is, in addition to its basic ethical value, truth telling is a core value that underlies a physician's role as a healer and patient's advocate. This patient is asking the physician to falsely certify a disability form. Falsifying a disability form is both unethical and is viewed as a fraud by medical licensing authorities. This physician should decline to complete the form. However, the physician remains obligated to assist the patient to the greatest to their ability within the scope of ethical conduct. This physician should assist the patient by discussing option for her to work while pursuing an education.
Okay, next. 67 woman comes to the physician because 1 year history of non-productive cough and progressive shortness of breath with exertion. Her symptoms were not a problem at first, but now has trouble walking her dog because of shortness of breath after walking 1 block. She has not had fever or any other symptoms. She has no history of illness, no medication, doesn't smoke. She retired from her position as a secretary 5 years ago. Vital signs normal. Pulse oximetry on room air is 92. Examination shows no cyanosis. Fine dry crackles are heard on both lung bases. Exam of the hand shows clubbing. There is no peripheral edema. Checks X-ray shows fine line linear opacities in the lower third of the lungs bilaterally. CT scan of the chest confirms an interstitial pattern. PFTs show FVC of 48 and predicted and diffusion capacity of the lung. Hmm. FCV is 48. Diffusion capacity of lung for CO is 55.
It is restrictive lung disease, isn't it?
Probably, yeah. Which of the following is the most appropriate next step?
And CT scan confirms an interstitial pattern, like
Yes.
ILD, interstitial lung disease. So confirmatory is biopsy. Anything regarding lung disease confirmatory is biopsy, as far I know. Okay. This patient's presentation and diagnostic studies are consistent with the diagnosis of ILD. A lung biopsy is the most appropriate next step given the severity of our symptoms and are significantly impaired pulmonary function as well as lack of apparent risk factors to direct the clinician toward an underlying cause. ILD encompasses a heterogeneous group of disorder. ILD encompasses a heterogeneous group of disorder that results in pulmonary fibrosis and progressively impaired lung function. Causes include various infection, occupational and environmental exposure, drug-induced pulmonary toxicity, radiation-induced lung injury, connective tissue disorder, hypersensitivity pneumonitis, and idiopathic disease. Patient classically presents with progressive dyspnea and chronic non-productive cough. Inspiratory crackles and hypertrophic osteoarthropathy may be present on physical examination. Chest imaging tends to show interstitial opacification in the periphery of the lung, though radiologic pattern dependent on specific underlying cause. Okay.
Next.
Okay. Can
2 year
you can you remember like when umbilical usually umbilical hernia regresses over time, isn't it? When we need surgery, there is a question we have done
Mhm.
previously. Maybe,
The the one we just did or another one?
maybe recently we have done.
Mm,
Is there anything like that, like when we should look for umbilical hernia?
when you should do
Oh,
the
okay, elective surgery around age 5. Okay, that is the thing. That is the thing.
oh, okay, for the day for the kids. Okay.
Yes, umbilical electric surgery around age 5.
Mhm. That was your question?
Yes, it
Okay.
is spontaneously closure. It is usually spontaneously closes.
Mm-hmm.
If it does not spontaneously closes, then we need to do surgery around age 5. That is my question.
Okay. Got it. 2 year old boy brought to physician for a follow-up exam 2 weeks after being treated for an ear infection. He has been treated for 6 episodes of otitis media and 1 episode of pneumonia since birth. 3 months ago, he underwent placement of tympanostomy tube. He currently takes no medication, appears well, 75% for length and 25 for weight. Exam shows zero point 0.5 to 1 centimeter firm non-tender mobile lymph nodes in the anterior cervical chain. Tympanostomy tube are in place bilaterally with no discharge. Labs, hemoglobin, I believe is fine. Hematocrit fine, leukocyte fine, platelet count fine. IgM, oh, sorry, IgA, I think, oh, it's here. IgA is low, IgG is normal, IgM is normal, so only IgA is low. Which of the following is the most appropriate next step in management?
So it's selective IgA deficiency.
Mhm.
There is a ear infection, so it is selective IgA infection. Selective IgA deficiency. So in selective IgA deficiency, this patient's sorry, IgA deficiency is most likely IgA deficiency is most like IgA deficiency is most likely cause of this patient's current infection. Selective IgA deficiency describes a decreased or absent concentration of the circulating IgA, decreased or absent concentration of the circulating IgA with normal concentration of the IgG and normal or increased concentration of the IgM. IgA is a critical for immune health and functions by binding pathogens, surface antigens, targeting them for opsonization, complement activation, and phagocytosis, and coating mucosal surface to prevent colonization, adhesion, and invasion by pathogenic microorganism. There is clinical heterogeneity in the severity of the IgA deficiency. Some patients may remain asymptomatic while others suffer from recurrent sinopulmonary infection, otitis media. In younger patients with severe deficiency, failure to thrive is common. Anaphylactic reaction to blood products such as plasma, which contain donor immunoglobulin, are classic but uncommon. Treatment of IgA deficiency is directed toward the treatment of symptomatic infection. Asymptomatic patients do not require specific monitoring. Okay.
Can you read C this C?
Yes. Intramuscular injection of immune globulin. Injection immune globulin is incorrect. Immune globulin replacement is not routinely recommended for the treatment of selective IgA deficiency. Immunoglobulin replacement may be considered in patients with IgA deficiency who also demonstrate an associated IgG deficiency or by other qualitative defects in antibody production. Immune globulin is administered subcutaneously or via intravenous infusion.
Next. 42, woman comes to physician because of nausea and vomiting and abdominal cramping and swelling over the past 12 hours. She takes OCPA. She underwent appendectomy 5 years ago. Abdominal exam shows distension and moderate tenderness without guarding. Um, X-ray of the abdomen is shown. Which of the following is the diagnosis? Hmm, okay.
So adhesions are the most common cause of small bowel obstruction in patients in patients with prior history of intra-abdominal surgery. Obstruction of the small bowel occurs as a result of partial or complete blockage of the small bowel lumen. Partial or complete blockage of small bowel lumen from either intramural or extraluminal. For either intraluminal or extraluminal obstruction, it is typically present with nausea or vomiting and abdominal pain and distension. Partial small bowel obstruction allows a degree of continued flatus with diminished stooling, and completing small bowel obstruction results in obstipation, no flatus of stool or flatus. Small bowel obstruction has many potential causes, with formation of peritoneal adhesion following a previous intraabdominal surgery being the most frequent. On physical examination, small bowel obstruction typically with abdominal tenderness, distension, tympani to percussion, barbor, barbaric me, high-pitched hyperactive bowel sound, and potential complication of small bowel obstruction include mm, bowel rupture and or necrosis, which can result in sudden onset peritoneal abdominal signs, such as rebound tenderness and guarding. Abdominal X-ray typically show dilated small bowel loops. Abdominal X-ray typically show dilated small bowel loops and can also have multiple air fluid level. Management require bowel rest and IV hydration followed by surgical intervention if the obstruction does not reduce on its own. Partial small bowel obstruction may resolve with monitoring, supportive care, and bowel rest, whereas complete obstruction or any complicated partial obstruction are generally requires management through exploratory laparatomy.
You read A and D.
Yes, adynamic calculus refers to intestinal hypomotility without a small bowel obstruction, most commonly occurring after a surgery in the setting of electrolyte abnormality end-stage renal disease. This patient presents with diffuse, small and large bowel dilatation. In a patient prior abdominal surgery, mechanical obstruction secondary to peritoneal adhesion is more likely. And perforated abdominal viscous would cause peritonitis guarding abdominal examination, while small bowel obstruction are complicated by necrosis and perforation. It is rare and this patient not show signs of perforation. On imaging, perforation would show free intraperitoneal air. Okay, just looking at the X-ray, can you diagnose is it small bowel obstruction?
No,
Yes,
no, I cannot because I thought the large intestine was also
involved.
yeah, but he says no, he's not involved on this one. So no, I cannot diagnose by the X-ray.
In the large intestine, there may be presence of hostra,
Mm-hmm.
and there is no hostra in here. And I don't know, it is very tough. Just
Yeah,
looking at the
I really cannot do it from just yeah.
okay,
Okay. 22 woman comes to the physician because of a 2-day history of severe shortness of breath. Over the past week, she has been taking ibuprofen for fever, chills, and muscle pain. She has no history of serious illness and takes no other medications. Temperature is high, pulse is high, and irregular, respirations are high, BP low, exam shows regular venous distension, crackles are heard throughout both lung fields, S3 gallop is heard, pulses are decreased in the upper and lower extremities, X-ray of the chest saw cardiomegaly and perihilar fluid. Okay, ECG shows frequent premature ventricular contractions, echo shows cardiomegaly with normal valve function and ejection fraction of 18%. Her estimated cardiac output is low. Which of the following is the most likely diagnosis?
okay. In ischemic cardiomyopathy, there is low ejection fraction. I don't know why. Sorry.
Hmm?
I said that like in ischemic cardiomyopathy is much more common in older. Look at option D first. Ischemic
D.
cardiomyopathy is the D for dog, D for donkey.
Mm-hmm.
Okay. Ischemic cardiomyopathy is much more common in older patients unless there is a family history of early cardiac disease. It is most often caused by chronic artery disease. Wall motion abnormality are often noted on echocardiography corresponding to the region of the affected by ischemic changes. Okay, they do not say clearly about the ejection fraction. Okay, so severe acute myocarditis is the most likely diagnosis in this patient. Myocarditis refers to inflammation of the myocardium. Therefore, inflammation of the myocardium. There are numerous causes, including infection, Coxsackie virus, parvovirus B19, Coxsackie virus, parvovirus B19, toxin and medications, doxorubicin, and connective tissue disease, SLE, sarcoidosis. This patient has experienced viral prodrome prior to the presentation. Acute myocarditis has a broad clinical presentation ranging from asymptomatic disease to severe heart failure. Patients are also at risk for arrhythmia as a result of disruption of the cardiac conduction system, as myocarditis may be difficult to distinguish from pericarditis and acute coronary syndrome as well of these as well of these disorder to present with chest pain and ECG changes and increased serum cardiac system. Acute myocarditis may be difficult to distinguish from pericarditis and acute coronary syndrome. All of these disorders tend to meet the presence of chest pain. ECG changes increase serum in cardiac biomarkers. Echocardiography can aid in make the diagnosis and treatment, and the patient's severe ejection fraction reduction is consistent with the disease process affecting the myocardium. Okay.
Can you read B?
Yes.
Mm-hmm.
Acute pericarditis can also present with dyspnea and chest pain in the context of fever and recent viral infection. In the context of fever and recent viral infection, uh, pericarditis typically characteristics ECG findings with widespread non-contiguous ST elevation and PR depressions. A normal ejection fraction is also expected on echocardiography, and fluid may be observed in the pericardial space. Pericardial effusion Pericardial effusion may progress to pericardial tamponade if the expansion of the myocardium and ventricular filling are impaired. Fluid will likely be visible in the pericardium on echocardiography as well as reduced ventricular movement. Okay.
Okay, so they are saying it's not ischemic cardio because she's young, and it's not acute pericarditis because you will see ST elevations via depressions, and you will see the fluid in the pericardial space. and it's not tamponade. You remember the signs of
Backstrides,
uh-huh. That
hypotension, distended neck vein, distant heart sound.
is she has hypotension. You said distended neck veins.
Yes, JVD distension,
She has JVD distension. And what was the third one?
distant heart sound. Like you can't hear the heart sound.
Okay, she doesn't have the distant heart sound. Okay. Okay, I guess. A study is conducted to determine if hemoglobin A1C greater than 15% predicts diabetic retinopathy. A result showed that 88% of all patients without diabetic retinopathy had an hemoglobin below 15%. Which of the following is the most accurate interpretation of this result? Oh, my lord.
So how it is done?
I
Okay,
don't remember
I'm
now.
reading the explanation.
Read it.
Okay, specificity describes the proportion of the people who do not have the disease who test negative and is calculated by true negative divided by true negative plus false positive. A specificity increases the false positive. Specificity de- uh, a specificity increases the false positive decreases. A highly probable a highly specific test allows the clinician and the patient to be confident that a positive test confirms the presence of the disease. With a test with poor specificity, if positive, does not provide strong evidence or confidence that the patient does in fact have the disease. In contrast, sensitivity is the ability of a test to detect a disease if it is present. A test is described A test is described as sensitive if it it has a high likelihood of disease detection and therefore a low likelihood of false negative or low likelihood of false negative. High sensitivity is useful in ruling out of a disease. In the study, described hemoglobin greater than 15% was present in 12% and not present in 88% of patients without diabetic nephropathy. Okay, please explain.
No, I cannot explain that one. I cannot explain that one. I forgot everything I've learned during my videos. But I feel like if you watch those videos, it will make sense. I just forgot, completely forgot what was. Yeah. Mm, I cannot
Okay.
explain. Can you read CD?
Yes, negative predictive value is 88% is incorrect. Negative predictive value is the likelihood that a person does not have a disease and given a negative test can be calculated as negative predictive value true negative divided by true negative plus false positive. The results of this study do not allow for the calculation of the negative predictive value. Positive predictive value is 88% is incorrect. The positive predictive value is the likelihood that a person has a disease and given a positive test and can be calculated positive predictive value true positive divided by true positive plus false positive. The results of this study do not allow for the calculation of the positive predictive value. Okay.
Okay. If
Okay,
I
can you
remember,
give me 5 minutes?
yeah,
Like,
had the disease. Positive predictive value is the test is positive and you have it. So it's just the switch. So here They're saying the
Okay,
person
can you
don't have.
tell this thing again, like
Okay,
specificity?
sorry,
Okay,
sorry. I'm gonna try to do different specificity versus negative, so you can see that you can hear the difference. Specificity,
yes,
you don't have the disease and your test is negative.
okay,
Negative predictive value, your test is negative and you don't have this disease. You see, it's the same thing, it's just switching one which one goes first.
yes,
Specificity, you don't have the disease and your test is negative.
yes,
Negative predictive value, your test is negative first and you don't have the disease. Same thing with sensitivity. You have the disease and your test is positive. Positive predictive value, your test is positive and you have the disease. That's kind of how that guy did it. So if you look at the question, the question is a result shows that 80 whatever percent of patients don't have the disease and their test is whatever negative. You see, don't have
yeah,
the disease, the patient don't have the disease and the test is negative. So that would be specificity instead of the negative predictive value. Don't have the disease, test is negative.
okay,
Does it make sense? A little bit of sense. If I
yes,
remember from those videos, that's kind of
yes.
how they.
Like
they
specificity is you don't have the disease and the test is negative, and the
mm-hmm,
negative predictive value is you have uh, the test is negative and you
mm-hmm.
don't have the disease.
Exactly. So it's easier when you compare it like that. Specificity versus negative, and then sensitivity versus positive. Yeah.
Sensitivity means that you have the disease
Mm-hmm.
and the test is positive,
Mm-hmm.
and positive predictive value is the test is positive and
Mm-hmm.
you have the disease.
Exactly. You got it. Yep.
Okay,
Okay. Let's take
okay,
the
I'm
break.
coming. Okay,
Mm-hmm. By her mom because of a 3 day history of pain and pressure on her face. Pain and pressure in her face, itchy eyes, and decreased hearing in both ears. She has not had fever, or chills, or muscle pain, or nausea. Acetaminophen has not relieved the symptoms. She takes no other medications. A year ago, she had a similar episode and was successfully treated with azithromycin therapy at the urgent care center, and her mother requests another prescription of azithromycin. The patient, two brothers, have well controlled asthma. Her vital signs are normal. Exam shows a supple neck with a few shorty lymph nodes in the cervical chain. Conjunctiva have a cobblestone appearance. The inferior nasal turbinates are edematous. The tympanic membranes are injected bilaterally. There is moderate mucus in the posterior pharynx. Tonsils are not enlarged. The lungs are clear. Which of the following is the most appropriate next step in management?
okay, okay. It's allergic rhinitis. Oh, so is allergic rhinitis is a common cause of in upper respiratory infection in children, in teens, or in adults. Frequent allergens include dander, pollen, dust mite, mold, animal dander. It commonly presents with rhinorrhea, sneezing, cough. It may be associated with allergic conjunctivitis as well as which presents with itchy, watering eyes. Physical examination may disclose inflamed nasal turbinate, that is cobblestoning on the posterior pharynx and upper eyelid, retracted and injected tympanic membrane, and infraorbital darkening. Chronic nasal obstruction can lead to impairment of the sinus discharge, which can lead to development of the sinusitis. Bacterial inoculation can also occur, leading to bacterial sinusitis with fever, facial pain, purulent rhinorrhea, and cough. Risk factors include a personal or a family history of atopy, early exposure to allergen being the firstborn child, and childhood use of antibiotics. The diagnosis is clinical and the treatment includes second generation antihistamine as well as glucocorticoid nasal spray which reduce the inflammation and allow appropriate nasal or sinus discharge. This patient presents with facial pain likely caused by sinus obstruction and a sinus obstruction in the setting of nasal inflammation. Further evidence by injected tympanic membrane with reduced hearing. However, she has no signs of bacterial sinusitis, such as fever, purulent nasal discharge. Thus, in conjunction with allergic conjunctivitis, she is experiencing the most likely cause of symptoms of allergic rhinitis, and she should be treated with oral antihistamines such as loratadine.
You will
Okay.
see an
Yes. Ceftriaxone therapy is used in the treatment of variety of infections such as community acquired pneumonia, bacterial meningitis, acute otitis media. These patients itchy, watery, edematous turbinate, and injected tympanic membrane are often consistent with an allergic cause of infectious disease. And prednisolone therapy is often prescribed for the first line of autoimmune and inflammatory disorder. While it may reduce the inflammation associated with patients' allergic rhinitis, prednisolone has a variety of the adverse effect and would not be the first line. Prednisolone has a variety of adverse effect and would not be the first line therapy. Her initial treatment should include antihistamine. Okay.
76 women scheduled to undergo right knee arthroscopy at an ambulatory surgery center. Before the procedure begins, the surgical team confirms the identity of the patient, the procedure being performed, the site of the procedure, the patient's position, the availability of the equipment. The procedure is then completed without complication, and the patient is discharged home 4 hours later. Which of the following is most likely increased at this center as a result of the pre-procedure actions of the surgical team? What is increased? Okay.
Okay. Get ready for explaining me. Okay. Despite best efforts, surgical reliability remains prone to error, including performance of incorrect procedures or surgery performed at wrong site or on the wrong patient. The Joint Committee University protocol for preventing wrong site, wrong procedure, wrong person, wrong surgery was developed to reduce such error and improve surgical reliability. Steps include preoperative verification of the patient's identity, and the procedure should be performed and the surgical site. The patient should be involved in the verification process whenever possible. Any discrepancies or questions should be addressed. The use of a checklist can assist in ensuring the standard verification process. The surgical site should be marked by the surgeon who will perform the procedure, and the surgical mark should be both unambiguous and positioned such that it will be visible after the surgical drape is placed. Additionally, a verification timeout should be performed prior to introduction of the anesthesia. to verify patient's identity, the procedure, and the surgical site.
Okay.
Okay.
That's it.
What is reliability? What does this mean?
I don't know. I think it just means. Let me Google it. 'Cause listen.
I understand the explanation, but
You don't understand it? Yeah, it's the word reliability. Definition. Being dependable, trustworthy, consistently performing as expected. Being consistent, being dependable, and being trustworthy. Okay, so basically, trust that this is the right surgery at the right site. I'm guessing.
okay.
I'm guessing. Medicine.
In the exam, I fail to understand this type of words.
Yeah, of those. Yeah, I know. Me too. Me too. Indicates how much a test or procedure is likely to produce the same result on the similar condition in repeated trials. So you do the thing over and over again, it should give you the same result,
Okay,
basically. Yeah. Mm. So basically, if you keep doing that same pre-procedure thing where you confirm everything, you always get a good like the surgery will also always be in the right place, right patient, right side. If you keep doing that pre-procedure thing, that's kind
okay,
of what they're saying. Next, immediately after extubation, following a total thyroidectomy, 72 woman has stridor and shortness of breath. She has a history of TIA and coronary artery disease. Her only medication is aspirin. She appears to be in distress and is gasping for air. Pulse is high, respiration high, BP high. Exam shows an intact surgical incision and no ecchymosis. Blood cells are decreased bilaterally. Arterial blood gas is on 40% oxygen, shows pH is acidic. Let me confirm. Yeah, pH is low, PCO2 is high, PO2 is high too, oxygen saturation, I guess that's normal, not sure. Which of the following is the most likely diagnosis?
okay.
Is what respiratory acidosis?
Yes,
Okay.
pH is low, PCO2 is high, oxygen saturation is normal. After thyroidectomy, hypocalcemia can happen due to parathyroid gland destruction. A laryngeal paralysis can happen, but breath sound is decreased bilaterally. Okay, another. Okay, like breath sound is diminished or absent in case of tension pneumothorax too, isn't it?
Vessel indicates. Uh-huh.
And there is hyperresonance, like if we percuss the patient, there may be hyperresonance, but breath sound may be absent in case of uh, tension pneumothorax also. Okay. So thyroidectomy, a common surgical procedure, is often used in the management of the hyperthyroidism, thyroid cancer, hyperthyroidism, thyroid cancer, and goiter. The thyroid gland is situated anterior to the trachea. The thyroid gland is situated anterior to the trachea, consists of two lobes that are connected by small stemmas. The thyroid is located near a variety of the vascular and the neurologic. The thyroid is located near a variety of the vascular and neurologic structure. The recurrent laryngeal nerve run posteriorly. The recurrent laryngeal nerve run posteriorly to the lobes bilaterally. They provide muscle innervation. They provide muscle innervation for both abduction and adduction of the vocal cord, as well as sensation to this region below the glottis. Special care is taken to identify these nerves during thyroidectomy due to thyroidectomy to avoid nerve injury, often with direct intraoperative nerve monitoring. Unilateral recurrent laryngeal nerve paralysis. Unilateral recurrent laryngeal nerve paralysis can lead to voice hoarseness caused by the inability to abduct the vocal cord on the side, whereas bilateral paralysis can lead to airway obstruction as both vocal cords remain in the medial position. This patient has respiratory distress with audible stridor indicating an upper airway obstruction, the likelihood of which is further reinforced by the decreased breath sound and decreased breath sound bilaterally caused by poor air movement through the obstruction. Given the onset of this patient's symptom immediately after the surgery, the most likely cause of this presentation is bilateral recurrent laryngeal nerve paralysis leading to vocal cord paralysis and airway obstruction. Okay,
With E,
yes. Tension pneumothorax presents with dyspnea, hypoxia, tachycardia, hypotension, tracheal deviation, unilaterally absent breath sound. It can rapidly lead to cardiac arrest if not identified. This patient has bilateral breath sound and is hypertensive, making tension pneumothorax unlikely. Okay, tension pneumothorax commonly presents unilateral absent breath. So unilateral. So bilateral tension pneumothorax usually don't happen.
tension pneumothorax. I guess not. Tension
Okay.
pneumothorax. But another key is that it presents with hypotension, and this patient has like really severe hypertension.
Yes.
So another thing also. Okay. Next, 46 men with hypertension comes to the physician for routine exam. The physician enters the room. The patient says the office staff were talking about him in the waiting room. The patient has declined antihypertensive med in the past. Today he declines it again, saying it does not matter because the war is going to end soon. He does not drink alcohol or drugs. He lives alone and has minimal contact with family. He says he has one friend and spends his free time playing video games. He was at home for an accounting firm. He appears fearful and older than his stated age. He wears an overcoat and woolen hat, although it's super hot outside. Pulse is fine and regular. BP is super high. Limited physical exam shows no abnormalities. On mental status is euthymic and odd effect. He makes minimal eye contact with the physician and appears anxious when questioned. He says he has not had anxiety or changes in mood. Cognition is intact. He answers questions appropriately. His thought process is linear. He reports no hallucination. Results of lab studies are within reference. Which of the following is the most likely diagnosis?
So what is your diagnosis?
I was between delusional and schizotypal. Schizotypal because of what she's wearing, and delusional.
Schizotypal is
Yeah,
like thinking, magical thinking.
yeah, yeah.
Okay.
It's the magical thinking and the weird clothes. I don't know why I was thinking delusional.
What type of delusion you are thinking?
I don't know. I don't know why. Hmm, I don't know. I think when he said the world is gonna end soon, but I don't think that's a delusion.
I think that's just
So in
yeah.
in this question, what is the striking point? Which line is the striking point?
I don't know. The one that gave me the that helped me different. I think it was the clothes, but I don't know if that's what's supposed to be the.
Is the
Mm.
clothes like in the description? Is there anything regarding the clothes in the cluster A personality? Cluster
Uh,
A is like living alone, and they do not care about themselves.
oh, okay, then yeah, because he says that he's living alone and he looks older than his age, so he's not taking care about himself, and yeah, so I guess that would be also the yeah, I guess that would be.
I'm reading this because I have some sort of similarity. Okay.
Oh, oh, okay. Okay.
There is a problem while I have studied psychiatry. Uh,
Is that what you want to do? Psych?
Sorry,
Is that what you want to do for your residency? Psych? You want to do psychiatry?
not really actually,
No, really. Okay.
but I love psychiatry. Psychiatry is a good subject.
Okay.
Okay, schizotypal personality disorder is one of the cluster A, the odd or eccentric cluster personality disorder according to the DSM-5. Personality disorder are persistently maladaptive ways of relating to the self and to the society that typically appear by the adulthood. Schizotypal personality disorder is characterized by odd behavior and thinking and a constricted affect. Patients with schizotypal personality disorder may have strange, overly metaphorical, magical thinking, though they fluctuate in the degree of their conviction about their beliefs while differentiates these beliefs from the fixed delusion of the schizophrenia. The strange belief may also manifest as eccentric appearance. Patients may experience patients may experience somatosensory illusions. Patients may experience somatosensory illusion or other abnormal perception. Patients with schizotypal personality disorder may appear to lack interest in cultivating relationship as a result of inability to interpret others' motivations and may be deeply distrustful and anxious around others.
Yeah. Mhm.
Okay.
Next. Next, yeah. 4-year-old girl brought to the office by her mom because of 1 week history of vaginal itching. The mother says her daughter is scratching her vaginal area frequently and the area appears irritated. The patient has not had fever, pain with urination, or urinary frequency. She has been toilet trained since she was 1 year old. The mother is not concerned about sexual abuse. When questioned alone, the patient says no one has touched her inappropriately. Exam shows redness of the vaginal area. There is no vaginal discharge, foul odor, bleeding, tears, or ecchymosis. Which of the following is the most appropriate next step?
Okay. Recommend the patient switch to cotton underwear and avoid bubble bath. Okay. Vulvovaginitis is a vaginal itching and erythema, and it can have variety of causes. When present in a prepubertal child, a, when present in a prepubertal child, a careful investigation, a careful investigation into the possibility of sexual abuse should also occur. Other causes of vulvovaginitis in a child include poor hygiene, foreign bodies, usually toilet paper, occlusive clothing, exposure to irritants. Less commonly, causes include infections such as pinworm, Streptococcus pyogenes, E. coli. Foreign bodies and infections are frequently associated with foul odor and vaginal discharge. Initial treatment include hygienic improvement and the avoidance of irritants, recommending that the patient switch to cotton underwear and avoid bubble baths, which is most appropriate next step in the management of these patients' non-specific vulvovaginitis. If the vulvovaginitis is recurrent and does not respond to conservative measure, further evaluation with vaginal culture may be appropriate. Okay.
Okay. 87. Man comes to the physician because of 2-day history of visual changes in his right eye. Okay. He noticed that the lines of his daily crossword puzzle look curved and the blinds in his apartment appear wavy. He wears magnifying lenses for reading. There is no pain in his eye, no photophobia, no history of trauma. He had cataract removal from the right eye. 5 years ago, there is no history of serious illness. On exam, visual acuity is 20 out of 200 in his right eye and 20 out of 100 in his left eye. The right pupil is irregular, but is reactive to light. The left pupil is round and reactive. The examination finding is unchanged since his cataract operation. Palpation of both globes through closed eye shows no abnormalities. His lenses appear clear. Which of the following is the most appropriate next step in diagnosis?
Okay, what is your clue in this question
Clue for what? I don't,
for
I don't, I
diagnosis?
don't, I don't even think I diagnosed it right. I think I just guessed because there is no way I diagnosed macular degeneration. There is no way I diagnosed that. I think I just
Because
guessed.
a drusen body or presence of like age-related macular degeneration has drusen bodies, dry drusen, but there is no fundoscopy examination.
There is no
Only
fun.
thing they actually add in this question, like the apartment appear wavy. This is
Mhm.
one thing I can remember. Okay. So age-related macular degeneration. Age-related macular degeneration, acquired retinal degeneration, characterized by dysfunction of the retinal pigment and accumulation of macular drusen. The hallmark accumulation of macular drusen. The hallmark of AMD, age-related macular drusen. Drusen represent yellow subretinal extracellular deposits of lipoproteinaceous material. The underlying cause is not completely understood, but a combination of environmental and multiple genetic risk factor is likely involved, including genes associated with complement regulation and autophagy. Age-related macular degeneration is a leading cause of non-reversible is a leading cause of non-reversible blindness in developed countries. Early stages of the disease may be asymptomatic or characterized by insidious blurring of metamorphosia, a visual distortion in which straight lines appear curved. In advanced stage, profound vision loss may result from retinal geographic atrophy or choroidal neovascularization with associated macular edema, exudation, hemorrhage. Risk factor for age-related macular degeneration include smoking, genetics. The diagnosis is established by a dilated fundoscopy. The diagnosis is established by a dilated fundoscopy examination to evaluate the retina. Antioxidant and vitamin supplementation are helpful for delaying the progression of non-exudative AMD, while exudative AMD is treated with intravitreal injection of the monoclonal antibody against vascular endothelial growth factor. Okay.
Okay, can you read? Oh, where was I? B and C.
Yes. B and C. Slit lamp examination is a method for examination of ocular structure under high magnification. This technique may be used to examine structure with anterior segment of the eye, such as slit lamp examination is done for anterior segment of the eye, such as cornea, iris, and lens, and within the posterior segment, including retina and optic nerve, usually as part of dilated fundoscopic examination. And visual field testing is used for detecting visual scotoma or visual field loss. It is useful for diagnosing glaucoma or other disorder of the optic nerve like IIH, idiopathic intracranial hypertension. It plays a little role in the diagnosis of AMD.
Okay, next. 27 woman comes to the office for health maintenance. She says she feels well. She has no history of illness, no medications, vital signs normal. Exam shows no lymphadenopathy. There is a 2 centimeter nodule palpated in the left lobe of the thyroid. The remainder of the exam is fine. Results of lab, including measurement of TSH concentration, are fine. Which of the following is the most appropriate next step in management?
Okay. Ultrasonography, a guided fine needle aspiration biopsy. Discovery of a palpable thyroid mass by a patient at home or during a routine clinical visit is common occurrence. The diagnostic workup focuses on ruling out the malignancy. Risk factor of thyroid malignancy include young age, the prevalence of the benign thyroid nodules, the prevalence of the benign thyroid nodules. Um, where I am. Benign thyroid nodule increases with age, radiation exposure to the head or neck, and a family history of thyroid cancer or associated congenital neoplastic syndrome. Multiple endocrine neoplasia type 2. All patients with a new nodule should be evaluated with serum TSH measurement and thyroid ultrasonography. Ultrasonography guided fine needle aspiration biopsy can be performed at the same time, which is recommended for patients with risk factor for malignancy and for nodule with concerning ultrasound features. Subsequent workup and management are dependent upon the results of the TSH measurement, ultrasound characteristics of the nodule, and the biopsy results.
You read B, I mean, this answer choice B, C, D.
Okay. Levothyroxine therapy and re-examination in 6 weeks. Re-examination of the thyroid gland in 6 months and repeat measurement of the serum thyroid stimulating hormone concentration in 6 weeks are not appropriate management option given the importance of ruling out of the malignancy, especially in a young patient. Okay.
Okay. Next. 17, boy brought to the ED by his mom because of 20-minute episode of severe chest pain, sweating that started 1 hour ago while he was watching TV. On arrival, he's alert and repeatedly expresses concern that something is very wrong. He reports that during the episode, his heart was pounding, he felt short of breath, and he was sure he was having a heart attack. He was going to die. 1 month ago, he had a similar episode that occurred in the evening, 30 minutes after his high school football practice. At that time, results of lab testing and ECG obtained in the ED showed no abnormalities. After the initial episode, he quit the football team and he has continued to limit his physical activity because he's afraid of another episode. He reports no insomnia or changes in appetite. His mother said that he was diagnosed with an innocent heart murmur at age 6 months, but it has not been noted on examination since the age of 1 year old. His paternal grandfather died of MI 3 years ago at the age of 68. The patient takes no medication, don't smoke, no alcohol, no drugs. He performs well in school. BMI is fine, temperature fine, blood pressure fine, no murmurs are heard. The remainder of the exam is fine. ECG is shown. Which of the following is the diagnosis? Jesus Christ.
What is your diagnosis? Just looking at the ECG.
I cannot tell the diagnosis just looking at the ECG.
It is supraventricular tachycardia. Like
See,
how we can diagnose SVT. In supraventricular tachycardia, look at the heart rate. Heart rate is more than 150.
heart rate, where are you seeing it? Heart rate, heart rate, heart rate.
Heart,
Oh, from the ECG.
yes, from the ECG.
Mhm.
From the ECG, heart rate is more than mm, like more than 150, and there is no normal P wave. There is an inverted P wave. There is no normal P wave.
Can
And
you tell me how you calculate the heart rate again?
heart rate is calculated by the from one P wave to another P wave, or from the one R wave to another R wave. In
Mhm,
this ECG, R wave calculation is easy. Like from the
mhm,
tall, from one tall R to the
mhm,
another tall R, how
mhm.
much small square is present?
Five, kinda.
5 or approximately 6. Okay,
Uh-huh.
5.
Two,
So
three.
5, uh, divide
Four.
it into 1500, and it is near about 300. Heart rate is about around 300.
Each small square is how much?
Each small square is 5, sorry, one large square is 5 small square.
Mm-hmm.
So you found one large square, that means 5 small square. So for calculating this heart rate from the small square, it is 1500 divided by the number you have found.
And if you wanna do calculate from the large square,
Large square is from by 1, sorry, 300 divided by the large square. Got my
300.
point?
Uh-huh. Uh-huh.
So
1500.
300 divided by 1 is 300, and
Mm-hmm.
1500 divided by 5 is again the 300.
Okay. So you say it was supraventricular because the heart rate is more than 300 and there is no.
More than
um,
150. More than
oh, sorry.
150 is
Uh-huh.
supraventricular tachycardia,
And
because
then
100 to 150 is sinus tachycardia. In sinus tachycardia, there is a normal P wave. That
mhm,
means P wave means the sinus rhythm is present. And in
mhm,
supraventricular tachycardia, look, there is no sinus word. So it is
Oh,
supraventricular. Okay.
okay. Got it. Get it. Um, okay, okay.
Okay,
Good.
I'm reading the explanation. In all SVT, the management is all the same, like carotid massaging or like vagal maneuver and giving adenosine. This is same for all type of SVT.
Mhm.
Like AVRT, AVNRT, this is one of the form of the SVT.
Mm.
So paroxysmal supraventricular tachycardia refers to an abnormally rapid heart rate, abnormally rapid heart rate. Abnormally rapid heart rate and rhythm originating from above the ventricles, typically with a regular rhythm and a narrow QRS complex on ECG. Patients with paroxysmal supraventricular tachycardia can manifest with acute symptoms of lightheadedness, palpitation, diaphoresis, syncope. Paroxysmal supraventricular tachycardia is typically caused by structural defect in the His-Purkinje system, causing a re, causing a re-entry pathway such as WPW syndrome, AVNRT, and AVRT, or PSVT. Paroxysmal supraventricular tachycardia may be provoked by alcohol, nicotine, caffeine, or psychological stress who are hemodynamically unstable, and cardioversion is indicated in the management of narrow complex tachycardia for patients who are hemodynamically stable. For a patient with hemodynamically stable, and attempts can be made to terminate the narrow complex tachyarrhythmia by vagal maneuvers, ice or cold water over the face, or adenosine. Okay.
Okay, can you read F?
Yes. Panic disorder. Panic disorder is characterized by recurrent panic attacks that are unexpected and associated with worry about future panics or avoidance of panic triggers. Panic attacks, which are acute fear or anxiety that peaks within minutes and is associated with symptoms of sympathetic hyperactivity such as tachycardia, heart palpitation, sweating, trembling, along with shortness of breath, chest pain, dizziness, gastrointestinal or anesthesia. Okay.
72 year old man comes to the physician for routine abdominal exam, shows non-tender pulsatile mass in the epigastrium. Abdominal ultrasound shows a 7.2 aneurysm. The physician reviews several studies of patients with abdominal aneurysm that are greater than 7 in size. The rupture rate is estimated at 20% per year. Following rupture of the abdominal aneurysm, one half of patients die before reaching the hospital. Um, for patients who do reach a hospital, the perioperative mortality rate is 50%. The mortality rate for patients who undergo elective repair of an aneurysm is 5%. After discussing the risks and benefits of surgical repair of the aneurysm, the patient decides not to undergo an operation. Which of the following best represents this patient risk for mortality from rupture of the aneurysm during the next year? Hmm.
Is it calculation thing?
I do not know. I did not even get it right.
Okay, I'm reading the explanation, then you make me understand. Correct Correct statistical interpretation is an important for conveying accurate information to the patient. In the scenario, a student demonstrate 20% annual rate of rupture of abdominal aortic aneurysm greater than 7 centimeter in diameter. Among ruptured aneurysm, the study defined 50% mortality rate prior to hospital evaluation, in addition to a 50% perioperative mortality rate among the remaining 50% patients who do not reach the hospital. In effect, 75%, 50% pre-hospital, and half of the remaining 50% who survived the surgery of those who experience aneurysmal rupture will die. However, the risk for rupture is 20% per year, representing 15% overall risk of mortality from aneurysmal rupture in a given year. This is represented by calculation 1 into zero point 0.5 pre-hospital risk of death, 1 into zero point 0.5 into zero point 0.5 perioperative mortality into zero point 0.2 annual risk of rupture is 0.15. I don't know how it
I don't know. I don't even understand what they're saying. I don't know. I don't know where they got that 75 thing. This is a really weird question. I feel like it's easy, but there is something with like there is a concept that I'm not getting.
yes,
Yeah.
not that easy.
Mm-mm. Let's skip this for now.
Okay,
I'll send that to my tutor. After. A 58-year-old man with an 8-year history of schizoaffective disorder, manic type, brought to the clinic for follow-up. 2 weeks ago, he was hospitalized for a manic episode. Risperidone was added to his medication regimen. The dosage was increased to the maximum recommended prior to discharge. Um, at that time, neurologic exam showed a mild
okay,
cogwheel rigidity. Yeah.
okay. Just I have found maybe.
Mm-hmm.
Okay, I'm sending you. Then we can discuss together.
Mm-hmm.
Okay, wait. Okay, you got it.
Mm, on
Okay.
WhatsApp? Where did you
No,
send
no,
it?
I sent it in the team.
Okay. Okay, I
Okay,
see.
okay. Annual rupture rate of abdominal aortic aneurysm more than 7 centimeter.
Mm-hmm.
So 20% per year. They said that 20% per year. The rupture rate is estimated that is 20% per year. So first 20% per year. Annual rupture rate is 20% per year. Then next thing is mortality rate after rupture. 50% die before reaching the hospital, and of 50% who do not reach the hospital, 50% die preoperatively. So the total mortality after rupture is 50% pre-hospital died, 50% of the remaining 50% equal to 25% in hospital mortality. So total mortality if rupture occurs, that is 75%. You got it. You
Okay,
got
okay,
this
okay.
part.
At that part.
Okay. So, and now we multiply all together. Like in the first thing, like 20% rupture, like 0.2, and 75% mortality if rupture occurs. That is 0.75 equal to 15%. You do the math.
Yeah, makes sense. Makes sense. Okay,
So maybe
okay.
it is easy.
Yeah, makes sense. Makes sense. Makes sense. Total rupture if orbital.
So
Total rupture.
first we will see the annual rupture rate. First we will see the annual rupture rate, that is 20%. Okay, then we will start calculating like mortality rate, 50% die, 50% before reaching the hospital. So total mortality is 50% pre-hospital death, and 50% of the remaining 50% equal to 25%. That is inpatient. So 50% pre-hospital death plus 25% in hospital mortality. Total mortality if rupture occurs, that is 75%. Okay.
Mm-hmm.
So 20% rupture and 75% mortality equal to 15% annual rate.
Makes sense. Makes sense. Okay. Okay. You got it?
Yes.
Okay, perfect.
You want to add something?
Nope. Now it makes sense. Bum, 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 bum. Okay, next. 58 men with a 8-year history of schizoaffective disorder, manic type, is brought to the clinic for follow-up. 2 weeks ago, he was hospitalized for manic episode. The risperidone is antipsychotic, right? Yeah.
Yes.
Was added to this medication regimen. The dosage was increased to maximum recommended prior to discharge. At that time, neurologic exam shows mild cogwheel rigidity. There was no evidence of tremors. Muscle strength was fine. He has no other history of serious medical or psych illness. His other medications are valproic acid and clonazepam. Today, examination shows drooling, masked faces, and decreased blinking. Huh. He has a slow shuffling gait with decreased arm swing. A reminder of the exam shows no abnormality. Mental status exam shows normal speech and mild anxious mood. There is no evidence of psychosis, which is the most appropriate next step in management.
There is slow shuffling gait. Oh, mask faces. Like Parkinson features.
Yeah, Parkinson. Mhm.
Risperidone is an antipsychotic that is antagonist to the dopamine receptor, which blocks dopamine signaling pathway non-specifically across the brain areas. Blocking the dopamine signaling in the limbic system decreases the psychotic symptoms, which blocking the dopamine signaling in the basal ganglia to medication induced Parkinsonism, including bradykinesia, tremor, cogwheel rigidity. In patients with extrapyramidal adverse effect, decreasing the dose is necessary to reduce the adverse effect, and cessation of the offending drug may be necessary.
You read A.
Yes. Addition to diphenhydramine in the medication regimen can help with extrapyramidal adverse effect associated with antipsychotic, such as dystonia, akathisia, aortic release. This appropriate step to decrease the dose of risperidone to help to reduce Parkinson's symptoms, as diphenhydramine would only offer transient benefit, if any, in the case which, if any, in the case such subacute or late presenting symptoms.
Okay, I
Okay,
thought
I
it.
don't get it. We
Yeah.
we yeah, we actually give this drug like diphenhydramine.
Mm-hmm. For the all the those side effects, right? Of
Yes,
anti.
like that extra pyramidal side effect, acute dystonia, akathisia, tardive dyskinesia, Parkinsonism, benztropine, diphenhydramine, BD. So why what is the problem if we give this drug?
I guess they're saying before giving something else, try to reduce what is causing the Parkinson, because it says here Parkinson was added, but the dosage was super increased to maximum. Maybe that's the key there. They increase the dosage, so try to reduce it. But then if they reduce it, wouldn't that bring back the mania? I don't know.
Yes, that's another question.
I mean, hmm, I don't know. I guess yeah, they're saying first try to reduce the drug before you add something else. I guess that's what they're kind of trying to say there. Hmm. Okay. Okay. Next.
Okay.
67-year-old man with metastatic lung cancer comes to the physician because of malaise and lethargy during the past 3 days. Medications are ibuprofen and lisinopril. He appears cachectic but person person, place, and time. His temperature is fine, pulse is high, respiration fine, blood pressure low. Exam shows decreased skin tone. The remainder of the exam is fine. Labs, hemoglobin is low. Hematocrit, I believe that's low too. Leukocyte, I feel like it's normal. Platelet count normal. Sodium normal. Potassium normal. Chloride normal. Bicarb normal. Where am I? Calcium high. Urea normal. Where am I? No, urea is high, glucose normal, creatinine normal, phosphorus
Now,
mm, should be low. Albumin, I don't know. What is albumin? Right here is low too. Which of the following is the most appropriate initial pharmacotherapy? So what does he have? Oh, he has hypercalcemia.
he does not have severe hypercalcemia, isn't
Not
it?
yeah, not severe. No, not severe.
Uh, as we have read the box, like on that box there is IV fluid addition on severe hypercalcemia, isn't it?
Mm-hmm.
So why we are adding, why we are giving normal salamine here? Because BP is low, 105/75. Is that the reason?
No, you just said that the boss said to give IV fluid.
Sorry,
So we could.
box
You,
said the IV fluid for
uh-huh.
severe hypercalcemia.
No, it said severe or it says just not severe. Let me see. I thought it said not severe. Hypercalcemia. Mm. What is the thing?
Look at the hyperkalemia. Sorry, hypercalcemia. There was a box in
There was
hypercal.
a yeah, there was a boss for hypercalcemia. Did I miss it? No. Uh, is it this one? No. No.
No,
What is
that
the
was the chart.
where is the hyper
Yes,
oh right
this
here.
one.
Okay.
Look,
So this is the asymptomatic or the low. It says no immediate treatment required, avoid tiresome, blah 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 blah. And then moderate 12 to usually no
this
immediate
patient
treatment.
has 11.8.
So it will fall on this. But it says it will follow this one, right?
Yes,
Yeah, and it says avoid thiazide, lithium, volume depletion, and prolonged rest. So avoid the volume depletion. But he is volume depleted.
okay, that's why.
He is volume depleted. Remember, you see, they're saying that decreased skin tone and his blood pressure is low.
Yes,
Hmm.
I I've seen that. Okay.
Hmm.
So,
Oh, let me plug my computer before it goes turns off again.
okay, lung cancer is often complicated by hypercalcemia caused by paraneoplastic parathyroid related peptide hormone production. This phenomenon uh, this phenomenon frequently occurs in the setting of squamous cell lung cancer may also occur in the squamous cell carcinoma on the head and neck, as well as breast and kidney cancer. Parathyroid hormone related peptide acts on Parathyroid hormone related peptide similarly similarly to parathyroid hormone, causing an increase in osteoclast activity via G protein coupled receptor. It causes increased absorption of the calcium in the intestine and the renal tubule. Bone pain is common presentation. Other symptoms include abdominal discomfort, muscle pain, weakness, polyuria, psychiatric disturbance. Hypercalcemia is often associated with hypophosphatemia caused by renal wasting of phosphates, subperiosteal bone resorption, nephrolithiasis, end-stage kidney disease. Management is determined by the severity. Management is determined by the severity of calcium imbalance and symptoms. Patients with mild hypercalcemia 12 with minimal or no symptoms may require no treatment. This patient albumin correct hyper okay, this patient with albumin corrected calcium concentration is 12 and altered mental status require immediate treatment with intravenous normal saline. This patient may This may be followed by administration of the calcitonin or and/or bisphosphonate, such as zoledronic acid. Patients should be monitored closely to evaluate volume status and electrolyte disturbance. Okay.
Okay. Next. 47 men brought to the ED because of severe left groin pain since he fell 2 hours ago. He is unable to walk because of the pain. He does not have pain in other joints. He has a 20-year history of ulcerative colitis. Only medication is prednisone. On exam, many attempts at range of motion of the left hip illicit pain muscle strength is intact distally and in the right lower extremity. These top pulses are fine. An X-ray of the pelvis and the left lower hip shows moderate loss of joint space and diffuse osteopenia. Which of the following is the most appropriate next step in management?
Okay. It's MRI of the hip, osteoporosis and osteopenia. Okay, why we are not doing DEXA? Start with this option B. DEXA scan is used to evaluate osteoporosis, which is defined as bone mineral density less than 2.5 standard deviation compared to a young normal population T-score. It can also be screening and for serial measurement in outpatient setting. However, in a patient with suspicion of hip fracture, However, in a patient with suspicion of hip fracture, a DEXA scan is not appropriate. Okay, that is the reason. However, in case of suspicion with a hip fracture, DEXA scan is not appropriate. Osteoporosis, and osteopenia, metabolic disease. Metabolic bone disease is characterized by diffusely low bone density. The most common risk factors are age, smoking, chronic inflammatory disease, corticosteroid use, estrogen depleting conditions in women. Such a demineralization and low bone density is often asymptomatic but increases the risk for fracture, for most commonly involving the hip vertebra and the distal radius. In this patient, diffuse osteopenia can limit the appearance for detection of the fracture on X-ray, and occult hip fracture is likely in the setting of osteopenia or osteoporosis. Advanced imaging such as MRI of the hip is the most appropriate next step in the management. Calcium and vitamin D management are the first line treatment for prevention of osteoporosis. Reduction of active osteoporotic risk factors should be pursued. Weight bearing exercise are recommended to slow deterioration of the bone mineral density. Bisphosphonates inhibit osteoclast activity. They are utilized once an individual and diagnosed with osteoporosis to reduce the further loss of bone density, bone mineral density. Okay.
Mhm. Next, 74 woman brought to the clinic by her family because of 7-month history of progressive confusion and urinary incontinence. During the past year, she has had multiple falls. She sustained wrist fractures 1 year ago, and her left tibia fracture and a left tibia fracture 3 months ago. Okay, she has hypertension, osteoporosis, depression. She's evasive when asked how much alcohol she drinks. She appears frail. Vital signs are normal. Physical exam shows a wide base gait and marked ataxia. She's unable to attempt the Romberg test. She's unable. Okay. Cranial nerve exam shows nystagmus and inability to move her eyes horizontally. On cognitive testing, she recalls 0 out of 3 objects. Labs, hemoglobin is low. Mean corpuscular volume is 102, so high. B12 is super
Higher.
high, and folate is normal. Mm. Which of the following is the diagnosis?
So he has alcoholic history. There is ataxia, white based gait. Rombergs cannot be done, and there is macrocytosis. Altogether, it looks like Wernicke-Korsakoff. Okay. Thiamine deficiency, vitamin B1 deficiency causes Wernicke encephalopathy and Korsakoff dementia. The classic triad of Wernicke encephalopathy Wernicke encephalopathy presents with encephalopathy, ataxia, oculomotor dysfunction, lateral gauge palsy, and nystagmus. Wernicke encephalopathy is reversible with treatment, but if allowed to progress may result in Korsakoff dementia. Korsakoff dementia is an irreversible condition that includes psychosis, anterograde or retrograde amnesia, and the consequent tendency to confabulate or verbalize false stories or memories to compensate for the inability to remember. Thiamine deficiency is common in patients with alcohol use disorder because poor nutritional intake. Thiamine malabsorption impairs cellular utilization of thiamine. MRI may show atrophy of the mammillary body. To prevent Wernicke-Korsakoff syndrome, all patients with sustained heavy alcohol use should be given thiamine supplementation, and patients present with acute intoxication should generally be given parenteral thiamine. While thiamine concentration may be decreased, this is not useful management, and it cannot be checked quickly. Thus, the diagnosis is clinical and should rapidly treated with thiamine administration. Okay.
You read C.
Yes.
C.
NPH, normal partial hydrocephalus, is a type of communicating hydrocephalus in which the ventricles are enlarged and leading to damage of the white matter tracts connecting the frontal lobes and basal ganglia. It presents with triad of cognitive impairment, urinary incontinence, and gait instability. Okay, okay. Can we take a break for 5-10 minutes?
Yes.